The end products of metabolism, uric acid, phosphate and oxalate from ingested food and tissue breakdown, are excreted by the kidneys along with minerals like sodium, calcium and magnesium. These crystalloids are in a supersaturated state in urine. Calcium phosphate and calcium magnesium ammonium phosphate remain in solution in acid urine but precipitate in alkaline urine. Calcium oxalate remains in supersaturation irrespective of whether the urine is acidic or alkaline. Despite supersaturation, the crystalloids remain in solution due to the presence of normal colloids. If the crystals are precipitated and bound by an organic mucoid matrix, a stone is formed. Mechanisms. The essential phase in stone formation is condensation of specific molecules within the collecting system. These molecules of mucopolysaccharides and mucoproteins form a matrix united by a strong chemical bond, with deposition of crystals in them as a secondary phenomenon. The mucopolysaccharides may be derived from bone matrix as when the bone is broken down in hyperparathyroidism, or may be derived from the connective tissue of the urinary tract. The origin of the mucoproteins is still obscure. They may be derived from the transitional epithelium. The formation of a stone in the urinary passage is influenced by the following factors. 1. Concentration. Concentrated urine predisposes to stone formation, while dilute urine diminishes the chances. 2. Reaction. Crystals of phosphate remain in solution in acid urine and precipitate in alkaline urine. Calcium oxalate and urate crystals precipitate in acid urine. 3. Colloids. The exact role of colloids is not known, but they help to keep the crystals in a supersaturated solution. 4. Inhibitor substances. Since normal urine is supersaturated with crystalloids, it is suggested that a stone is formed when inhibitor substances, such as pyrophosphate, mucopolysaccharides, citrate, magnesium, etc. are decreased. 5. Nucleus. A microprotein nucleus is essential for stone formation. Types. The most common constituents of kidney stones are oxalates, urates or phosphates, combined with calcium. About 75% of stones are composed of calcium oxalates, 10%, 12% contain some uric acid, and 5% consist of pure uric acid. Calcium. The normal range of urinary calcium in adults taking an ordinary diet is 100, 300 mg 2.5 to 7.5 mmol per day for men, and 100, 250 mg 2.5 to 6.25 mmol per day for women. Patients who pass calcium stones in general tend to show increased urinary calcium excretion, hypercalciuria. The prevalence of calcium stones is higher in those taking a low-fiber diet. A vegetarian diet predisposes to urinary bladder stones, while meat diet is claimed to predispose to kidney stones. Increasing the protein intake enhances urinary calcium excretion in normal subjects as well as in those with urinary stones. Calcium stones, being radiopaque, can be seen on a plain X-ray film. Oxalate. The normal urinary oxalate excretion is about 17, 40 mg, 190, 444 micromole per day. Less than 10% of this is from the diet. Patients with oxalate stones may have normal oxalate excretion. The colon is the major site of oxalate absorption. Increased absorption is common in fatty diarrhea. Crystals of calcium oxalate are found mostly in acid urine, but may also be present in neutral or alkaline urine. They may not be associated with increased urinary calcium excretion. Ingestion of rhubarb, spinach, tomatoes, strawberries, chocolate or tea produces a temporary increase in oxalates in all individuals. Secondary hyperoxaluria. It is possible to decrease the oxalate content of vegetables by using phosphate fertilizer. Uric acid. The average daily excretion of uric acid is 0.5 to 1.0 grams, 3-6 mmol. When the urine is strongly acidic, uric acid crystals are precipitated. This predisposes to urate stones. The mere finding of uric acid crystals in the urine does not denote abnormality in uric acid metabolism, but only indicates that the urine is strongly acidic. Unless uric acid excretion is estimated on a controlled diet, no conclusions can be drawn about uric acid metabolism. Uric acid stones are common in patients with gout and are also seen in the tropics. Pure uric acid stones are radiolucent. Phosphate. The normal daily excretion of inorganic phosphate is 500, 1500 mg, 1648 mol, in men, and 500, 900 mg, 1629 mmol, in women. Excretion of phosphate is not increased in patients with stones. Phosphates remain in solution in acid urine, but form a visible heavy precipitate in strongly alkaline urine. Urine kept for several hours frequently turns strongly alkaline because of formation of ammonia by urea-splitting microorganisms. The heavy deposit of phosphate formed has no clinical significance. Phosphate stones tend to form in the bladder when there is stasis and infection, e.g., in paraplegia or prostatic enlargement. Some infecting organisms split urea into ammonia, and phosphates precipitate in the strongly alkaline urine and are bound together by a matrix. Magnesium. Low urinary magnesium excretion and high urinary calcium excretion. Low magnesium calcium ratio predispose individuals with hyperparathyroidism to stone formation. These people may benefit from supplements of magnesium. Cystine. Cystinuria is an inherited condition with defective absorption by the renal tubule or the amino acids cystine, lysine, arginine and carnitine. Some of these patients excrete a large amount of cystine, 480, 3600 mg to 15 mmol, in the urine. Cystine crystals are hexagonal and are visible only in acid urine. Cystinuria patients are at a higher risk of kidney stones and impaired cerebral function. The loss of the essential amino acid lysine results in stunted growth. Treatment consists of increasing fluids, alkalinization of urine, and reducing methionine by reducing animal protein and substituting vegetable protein. Dietetic management. Fluids. Stone formation is a gradual process, and the tendency in a susceptible person persists throughout life. Vigilance with adequate fluid intake and diet is needed indefinitely. The fundamental principle in the treatment of kidney stones is to supply adequate fluids like water, coconut and barley water, sherbet, aerated water, fruit juice, and weak tea, in order to ensure the passage of over 2000 milliliter of urine per day. A heavy manual worker in a hot, humid climate should drink more fluids than a sedentary office worker in a cooler climate to compensate for the fluid loss through perspiration. The simplest guide is to drink enough fluids to see that the urine is very light in color. Dilute urine avoids concentration of solids and also tends to make the urine neutral, thus preventing the acid or alkaline reaction which predisposes to precipitation of crystals. Foods. Although the role of diet in the formation of urinary stones is not well established, it is advisable to restrict foods that are rich in calcium, oxalate, or uric acid, according to the type of stone formed. If a person with calcium oxalate stone cannot resist the temptation to eat an occasional strawberry or tomato, he should drink additional water for the next day or two. It is also claimed that milk and cheese, if taken with food rich in oxalate, led to the precipitation of non-absorbable calcium oxalate in the intestine. Vitamin A may be helpful in a person deficient in it. Prevention. 1. Adequate fluid intake. 2. Treat urinary infection. 3. Decrease calcium intake. 4. Restrict protein intake. Food rich in calcium, oxalate and uric acid. Calcium: beans, cauliflower, fig, egg yolk, milk and milk product, potato and molasses. Oxalate: beef, cashew nuts, chiku, chocolates, cocoa, custard apple, ground nuts, peanuts, rhubarb, spinach, strawberries, tea, tomato. Uric acid: fish, herring, fish roe, salmon, sardine, kidney, liver, meat extracts, soups, sweetbread.